It says, here's what I'm observing, here's what happened, here's what we're doing. Very simple. That's just a repeat. I can't tell you enough. Good documentation saves you headaches whether or not you're ever going to have a suicide. It's really, really important. When I was in training, it was back in the 60s, which was the heyday of, hey, let it all hang out, it doesn't matter, give your patients flowers and walk down the hall. We didn't document because it was too restrictive and too medicalized, and we didn't want to do that. And that was really stupid. Again, you can read this, I don't have to spend time with it. Basically, it says, document anything of any importance. Am I going bad?
You're doing well. While you're going
I can't turn around and tell you what that says, but you can read it.
While your battery's going back, can I ask you a question?
It should be there. Thank you. So what's important here? What are we doing when I'm not available? What about hospitalization? Why didn't it get accepted? And what are we doing as an alternative? What did I do if I felt the patient needed to be hospitalized? Precautions, treatment intensity or frequency. Anything of pertinence as to what I'm observing, what I'm doing about it. And if the patient isn't going to go along with what I want to do, why and what are we doing instead? Simple and straightforward. We're going to come back and talk a lot about informed consent and confidentiality. This is a good treatment recommendation, and that is get comfortable using the word suicide. Get comfortable so that you can use it with your patients each and every day. It's a perfectly reasonable word. It has certain meanings, but if your patient gets it from you that you're uncomfortable talking about it, then they're not going to be talking about it if you're thinking about it. That's going to set up an iatrogenic situation. You do not want to create a suicidal patient because you're unwilling to give them room to cathartic and talk about what they're thinking. Thoroughly assess risk. Get multiple sources of information. Do not rely solely on the presence or absence of suicide ideation. Formulate your assessment, document it, make a judgment. None of us are perfect at making judgments. You're not expected to be right every time. You are expected to make a judgment. My wife would tell you that I'm wrong most of the time. But that's not to say I don't have an opinion. It's not to say I haven't said something about what I'm thinking. The expectation is you're paying attention, you're thinking about it, you're making clinical judgments, and you're documenting those judgments. Have a clear treatment plan. Talk to the patient or client about that treatment plan, particularly about their suicidal thinking and or what else puts them at risk. Here's what I see going on with you. Here's what we're going to try to do about it. Here's what I need from you. Get them to be collaborators in the process. You're 90% of the way there when you get that far. Closely monitor the potential risk for suicide until that risk resolves. Use as many different forms of intervention as are reasonable and possible. Collaboratively assess with the client the treatment plan. How are we doing? How's it working? What are your thoughts about it? Routinely seek consultation. That's a very good piece of advice, by the way, because we can get blindsided very easily when we work by ourselves. So talk to your colleagues. Never seek consultation from a friend. If you work in an agency and there are 15 people available to you, pick someone that you probably aren't very close to. They'll be more honest with you. And consultation is designed to open your brain to things that you may not be seeing or things that you're thinking stupidly about. So don't talk to a friend. And document, and monitor. And once again, gee, I think that's redundant. Don't rely on the absence of suicide ideation as therefore the absence of risk. Go beyond what they say. Use your own brain. And why? Because when we look back at those who've died by suicide, and we look to see what did they say the last time they were asked about suicidal thoughts, before their suicide, what we find is that the great majority of patients deny that they had suicidal thoughts, and then they went out and killed themselves. That's why you have to look beyond whether or not the patient admits to suicidal thinking. Back in 2003, did you read yesterday that the MacArthur grants were announced, the MacArthur Genius Awards? Did you read that in the paper? Oh, I won't tell you the story. Never mind. So back in 2003, we gathered together 15 of the world's most significant clinical researchers, about adolescents and about adults, and we said, look, if we're going to teach the public and if we're going to teach professionals what to look for as acute risk factors, as warning signs, what should we tell them? Because we did an internet search and we found that on 200 sites that we examined where they have warning signs for suicide, we counted over 2,000 different warning signs. Now, that didn't make a lot of sense to us. It's hard to train the public and train professionals to 2,000 things that aren't truly warning signs. So we needed to get a clear sense of what is common to people before they suicide, in the days and weeks and months. Not lifetime, but acute risk. And we came up with a whole bunch of things, and then we caught them, put them into this acronym or mnemonic designed to help people remember them. So before we take a break, we're going to memorize this, okay? Because when you're doing a suicide risk assessment, it's not only being able to assess that, yes, they are depressed, yes, they have a drinking problem, yes, they have an eating disorder, yes, they have a family history of suicide, yes, blah, blah, chronic distal risk factors. But you want to know what to look for in the short run that says their vulnerability puts them at risk. These things make them much more explosive, much more potentially going to act out. Is path warm? The I stands for ideation, if indeed they express suicidal thoughts, verbally, in writing, in poems, in diaries, in journals, in instant messages. In any form, are suicidal thoughts communicated? If there's evidence of that, take it seriously. That's an acute risk factor. Suicidal thoughts, when they occur, precede suicidal behavior. So it's important. S stands for increased or exacerbated use of drugs or alcohol. They may be a chronic alcoholic. They may have had drug problems for the last 6 years, but if something is shown that they have blipped on the oscilloscope, that there's a spike in their behavior, that signals more acute behavior. We just completed a psychological autopsy study of 7 young suicides, all under the age of 18, in a county in New Jersey that all died by railroad suicide. They stepped in front of a train. Very rare behavior, but all 7 from the same high school did this behavior. So it was a cluster we were investigating. And it turned out that when we got all this data about these kids, that all 7 had a drug or alcohol problem, and the community was it was an upscale community, and they'd have parties, and the parents would approve of kids drinking at the parties, and sometimes they'd supply the liquor or supply marijuana. So it was a community that was very supportive of substance use. But all 7 of these kids also were acutely intoxicated at the time of their death and or within the last 32 hours before their death. And so the average blood alcohol reading at the time of death was 0.18, 3 times the legal limit. That was the average. One kid had 0.32. So acute intoxication is a warning sign. Saying, I don't have any reason to live. I don't have any purpose in life. Life is meaningless. Sense of purposelessness is the P. Ideation, increased substance use, purposelessness. There are 2 A's. One stands for anxiety, the other stands for anger. Anxiety comes in many forms, but for the most part, we're looking at restlessness, agitation, insomnia, things which express the inability to calm. Okay? The T stands for trapped, feeling caught between a rock and a hard place. Any expression that says, I'm stuck. I can't get out of this. H is hopelessness. I'm in an awful, no good place. Nobody gives a damn about me. Nothing's ever going to change. The cognitive triad that Beck talks about. Hopelessness is the H. W stands for withdrawal from everyday activities, from friends, from school, from usual connections. One of the most preventative and protective factors vis-a-vis suicide is good connections with other people. It's one reason why therapy works. If you have a good therapeutic alliance, if there's a good connection between patient and therapist, risk is going to go down as long as that therapist stays involved. The absence of that, withdrawal from usual connections, signals acute risk. Withdrawal. Then there's the other A, which is anger, not just being pissed off, but being rageful, wanting to get revenge, having excessive rage over time. R stands for increased recklessness or risk-taking behavior. 17-year-old whose sister killed herself a month ago who got 2 speeding tickets driving 80 miles an hour in a 35-mile-an-hour zone. And in the 1 year he's had his license, had no speeding tickets at all. But within 30 days of his sister's suicide, he's now reckless. Increased risk under conditions where you'd express him to be more at risk. And the M stands for dramatic mood change. Dramatic mood change. All of a sudden going from being okay to being depressed, or being depressed and all of a sudden, for no explainable reason, looking good. Okay? Is path warm? Out loud, verbally, and then we can take a break. We can't do it until you do this. I stands for? Ideation. Oh, now, come on. Close your eyes and do it. I stands for? Ideation. Good. And how many different forms can you think of ideation coming in? Can it be verbal, written, computerized, etc.? Expressed words saying suicide's on the brain. S. Okay, not chronic substance use, but increased or dramatic increase or change in substance use behavior. Okay? That's is. Ideation, substance use. You got that? P. Purposelessness. Very good. A. Anxiety, typically in the form of agitation or insomnia. T. Trapped. Some of you faded there. T. Trapped. Thank you. H. Hopelessness. W. Withdrawal. A. Anger. Not just being angry, but being vengeful, revengeful, really wanting to get back at someone. R. Terrific. And M. Dramatic mood change. Okay, you got it? You're going to say this in your sleep tonight. Is path warm? Now you've learned something. Take a break. Anybody know how long a break we're supposed to have? 15 minutes. 15 minutes. We're going to call you back here, give or take, on the hour.